great. So, it's a long, patients with dysautonomia have a long journey, and my own involvement with dysautonomia began in Cleveland when I was first in practice. I had a colleague, Tom Chalimsky, who was interested in autonomic dysfunction, something I had no training in, but I was delighted that he was in town, and I referred a number of my patients, including my POTS patients, to him. So when I relocated to St. Louis, which is my hometown, and my wife and growing family decided to move back and be closer to my aging parents so that we could take care of them, it became clear that in St. Louis there was no one. And so I had nobody to send my patients to. So I became that person. And so I went down to the basement of my hospital and I found an old tilt table. It was abandoned by the physical therapy department because guess what? It makes people faint. So they stopped using it. And I had an EMG machine which allowed me to record heart rate and deep breathing, and so just add water and I had an instant autonomic lab. And patients quickly beat a path to your door, whether directly or through other doctors who are also looking for someone to send these patients to, and cardiologists and GI specialists. I mean, they come from every other specialty. And I began to grow my practice in this regard. And 2 years ago, when I was here at this meeting, I had to say that I was a little burnt out. I was feeling a bit overwhelmed by what I call the symptom snowball, that managing the sheer enormity of the number of symptoms that my patients were having. I just found it exhausting. And if I was exhausted, imagine how exhausted the patients were and their families and their loved ones, and how exhausted people are hearing that, oh, it's all in your head. I mean, that is, to suffer this much and to be so discounted is just adding, it's a double whammy. It's just a slap in the face. It's like being kicked when you're down. So I had to get around that. And how did I get around that? So first of all, as physicians, I think it's important for people to realize that we were not trained in anything other than a biologic model. As docs, we need to have a sense of where this is all located, somewhere in the nervous system, or in the, somewhere in the physiology. And too often, the symptom snowball. It's not just dizziness and lightheadedness. It's the headache. It's the GI. It's the urinary tract. It's the sexual dysfunction, the thermoregulatory and sweating dysfunction, and I mean the list easily 30 plus symptoms per patient. And that's overwhelming for people. It's overwhelming for doctors. And what I needed was a biologic model to understand that. And that understanding really came from a lay journal, The New Yorker, 2008. Atul Gawande interviews Anna Louise Oaklander. And she describes a patient who developed an itch following a shingles on her scalp. And it was so severe that over the course of several years, she, even despite her doctors and nurses binding up her hands in boxing gloves and restraining her arms at the side of the bed, she would still find her way to scratch through. And one time, she scratched so hard that it wasn't just blood that was coming out this time. It was clear liquid, and she'd never seen that before. And she went to the emergency room and was horrified to find out that she'd scratched through the calvarium into her brain, and that was spinal fluid coming out. And what Dr. Oaklander did was to biopsy the skin around this and find that there were no nerves at all in the skin. So how can that be that skin with absolutely no nerves whatsoever was being interpreted as an intractable itch? Why is the brain making a wrong guess? Because it should be numb. But in fact, that's not the way the brain works. When we have phantom limb pain, when a Iraqi war vet comes back from the army and he's lost his arm, nobody told those neurons in the left hemisphere that that right arm is gone. They still think they're still there. They just don't have an end organ to find anymore. So, in fact, what happens is the arm becomes distorted. It's not only still there, but it's swollen, it's twisted, and it's exquisitely painful. And that pain is resistant even to morphine. Until Dr. Ramachandran came along and put a mirror in front of that missing arm and had the not POWs, but the war veterans put their missing limb behind it and take their good arm and move their arm around in such a way that they would look in the mirror thinking that this is actually my missing arm. And although cognitively you'd say, this can't be working, this can't do anything. In fact, it did. Those neurons, the activity, which we can see on functional MRI, actually began to shrink. They became less likely to be making wrong guesses, essentially. And so slowly, it's not a perfect therapy, but it's one of a number of therapies that have been found to be helpful for managing phantom limb pain. So this created a biologic model that I think most doctors could understand. And functional MRI has now been applied to fibromyalgia, another commonly discounted medical condition among physicians. Again, when we see the brain making a wrong guess, and we think that a lot of functional disorders, meaning where functionally there's a software problem, even though the hardware, the structure, is normal in the nervous system. And I think what we're dealing with is this symptom snowball of these functional symptoms where our brain is making a wrong guess. Yes, there are triggers. Yes, there's tachycardia. Yes, there's migraine. Yes, there's a lot of things going on. But I think this is really the biggest challenge, not just for the patients, but for the doctors to internalize and realize that there is a biologic model to help account for the reality of these symptoms. And in fact, all of us suffer from them. Not really suffer, but many of us have this experience in daily life. Have you ever had the phantom cell phone syndrome, where you felt your cell phone go off in your pocket and you go, wait, nobody called me, and you can swear that you felt the vibration in your. So I think that's it's a very common experience. If you go to the dentist and you get a shot of Novocaine, just because our lip is numb, we don't think it's gone. We think it's distorted, right? We think it's swollen. And we go and we check ourselves in the mirror and we see that it's perfectly normal. So these are universal experiences. It's just the way the brain works. And so we think a lot of these software problems are the brain making a wrong guess, and that we have a functional MRI ability to document these things. And we see this in fibromyalgia. We see this in a number of these disorders. I think the likelihood that you're going to have a symptom snowball is higher if you have migraine, because migraine is sort of a classic functional disorder where the structure of the nervous system is normal. You do an MRI of a person, and even in the midst of the worst migraine of their life, the MRI is normal. But we know that there's a spreading wave of cortical depression, not depression, but it's as though someone takes the volume button, turns it down on the neuron, and it just slowly spreads in a wave, 3 millimeters per minute. And if it stays in the back of the brain, called the occipital cortex, you might see a few flashes of light, or as one of my patients at Mount Sinai Medical Center in Cleveland called it, schwindels, little flashes, zigzag lines, lightning bolts. And if it stays in the occipital lobe, that's all you'll see. But if it moves into the sensory brain, then you start to have some numbness and tingling, which might move up the arm and make you feel like you're even having a stroke. So I think that patients with migraine are more likely to have these other functional syndromes. And I don't just think it, I know from the literature that that's the case. So we think that's one of the risk factors.
Let's talk a little bit about Dysautonomia International.
Sure.
How have you been involved with them, and how have you been involved with them?
I've been involved with Dysautonomia International because I believe in the problem. I believe in the cause. Obviously, I live it on a daily basis with my patients, and Dysautonomia International has provided a resource for my patients We started one of the first support groups in the United States in 2013. One of my patients was interested in starting a support group, and I thought that was a great idea. And then she passed the baton to 2 other patients, and so I have 3 people, one a patient, his wife, Jenny, and Kelly, and Brad. All 3 of them now run a support group that has over 200 members, and then even more that are online on our St. Louis Facebook page. And they have derived a lot of useful information from the Dysautonomia International website, and we include their materials in our binder that we hand out to all the new patients. Laurence Stiles and her group have done such a fantastic job helping, number 1, support patients with information. Number 2, provide a voice for those patients, not only with physicians but in Congress. And they're just a very well-connected group, and they're exceptionally, I think, effective at just not giving up, persistence at putting out the message and making sure that as many people as possible are learning about POTS. The duration of time, it's interesting to see the duration of time it takes to get diagnosed with your POTS is now finally shortening. It was 5 years, now it's 4 years. It's still too long, but I think that's hopeful.
Why is it important to get involved with an organization like Dysautonomia International?
Well, it depends who you are. I think it's important if you're a patient to find strength in numbers and information and referrals to physicians. I think it's important for physicians to be involved, to assist their patients, to become more well-informed, and hopefully to grow in their compassion by developing a biologic model that fits in with the way we're trained in medical school, and also to, I think there's a lot to be said for growing our compassion, even though we may not fully understand every symptom, to at least acknowledge that that person is in the right place, that you're going to support them as a physician, you're not going away. I've become a hugger because of my POTS patients. Like I said, 2 years ago, I felt a little bit burned out. I don't feel that way anymore. I'm energized. I'm enjoying what I'm doing. And, I feel like I'm a fellow traveler with my patients now. I don't feel kind of an adversarial, oh my goodness, here comes this symptom snowball. What am I going to do with all these symptoms? I'm now much more, I just feel like we're walking together with this problem.
That's a nice line. Do you have anything else that you want to add that you feel like I didn't ask you about?
I would just, just keep in mind that I know a lot of people have heard from their doctors, this is all in your head. And when a patient, after I've had my conversation with them, they say, "Doctor, are you saying it's all in my head?" I say, "No, it's in your brain. It is in your brain." And some of this is our brains making wrong guesses, just like the phantom cell phone syndrome. Some of it is absolutely biologic, and we've got to find that underlying cause. And often we have to treat both at the same time. In order to get people well, we have to take into account the entire person. Spirituality, their physical endurance, we have to build that up, their volume. There's so many things we can do. Cognitive behavioral therapy for sleep, a wonderful program online you can do. I refer my patients to a number of books. If you have headache, I strongly urge people to read Heal Your Headache by David Buchholz, and any number of newer books about diet. It's no surprise that what goes into our body might affect how we feel, and so we ought to investigate it and look into it and adopt a healthy diet that doesn't trigger migraine, and vigorous daily exercise to the best of our ability. Starting slowly, gradually building up. For many of our patients with POTS, you've seen all the wheelchairs, you've seen all the knee splints and trusses and various sleeves that people have to wear because of joint laxity. I'll have people start off lying down on a yoga mat and putting their feet into what's called a floor peddler. with straps, and just start very gently, and then graduate to a recumbent stationary bike where you're pedaling like this. Even a person with EDS, even with some laxity of the hips, should be able to do this with no resistance at all. That's fine. The main thing is to get your heart rate up. And I know that everyone's heart rate jumps when they stand up. It's harder if you're lying down or sitting down to get that heart rate up. So just start gently, be patient with yourself. You know, when you have chronic illness, you beat yourself up. There's another book I like. It's called How to Be Sick. Most of my patients, when they first hear me recommend a book called How to Be Sick, they say, wait, I don't want to be sick. Well, I get that. But while you're on your road to recovery, here is how to manage what can be your worst enemy, which is your own brain, which is the attitude. And one of those attitudes that's very common in chronically ill people is that we beat ourselves up. You know, why can't I do what my brother does? Why is everybody else out there in the world having fun and I'm not? Well, this book, through a perspective of Buddhism, teaches how to take joy in the obvious joy that other people are having. And instead of feeling resentment, actually experience the joy of someone out running in a park while you're stuck inside. And that way, suddenly you free yourself of this bond, this heavy chain of illness, at least for a few moments. And the more you can grow that, the more tolerable a chronic illness can be while you're waiting to get better, while you're doing all these other things that require a lot of effort.
Thank you so much.
My pleasure.
It's good talking to you.
Yeah.